Thank you, Speaker and Chairpersons. We shall now proceed to the second symposium for the day, focusing on MOGAD. I invite the chairpersons, Dr. A.T. Aliboy and Dr. T. Thivakaran, to introduce the speakers.
Good morning, and we'll get to the next symposium, which is on MOGAD. And we have two talks this morning. First one will be by Professor Flanagan from Mayo Clinic, Rochester, and he has been introduced before, so we'll get on directly to his talk, which will be on many facets of MOGAD.
Thanks so much. It's good to be back up here to talk about a hot topic at the moment, and nice to get the perspective of Dr. Mantelband too about how to discriminate this from MS. So some of the MRI features that we'll talk about and some of the clinical presentations in this talk hopefully will give you an idea for what MOG looks like. These are my disclosures here, but the focus today will mostly be on diagnosis. I'm not a neuroradiologist, but I'll show some images today that hopefully will encourage you to look at your own MRIs and try and help interpret them, as I think there's some relevant patterns here. So we'll talk about a few different clinical presentations, and we'll highlight the potential for MOG to also have severe attacks, which I think sometimes is under-recognized, but is something that we understand. I wanted to start off by just highlighting the Sri Lanka Mayo Clinic collaboration in MOG and Aquaportin 4 that began many years ago. Sean Peddock, who's part of the Irish Mafia that I mentioned earlier, and Bimsara set up this really nice collaboration and resulting in testing of many patients with MOG and Aquaportin 4. And I was able to sneak over some tubes so we can do some additional testing here. So I was able to get some over for us here. But a really exciting collaboration that led to an important study looking at the seroprevalence and clinical phenotype of MOG cases here, and really highlighting that MOG was more frequent than Aquaportin 4 in the region here in Sri Lanka. And I think it was 3.5-fold more common. And again, a younger age group than the typical median age we see for NMO or for multiple sclerosis. And MOG, as we'll talk about, is really optic neuritis dominant, I would say. I think in some recent studies, up to 70% of cases of all attacks are going to be optic neuritis. So you really have to be aware and engage with your ophthalmologist to see these patients. There was a relapsing course in 34% in Sri Lanka here, and most have a good outcome in the long term with an EDSS less than 6 in 94%. So I'll come on here. This was just to highlight, and I've mentioned this at this Congress before, this was highlighted in the MOGAD diagnostic criteria published in 2023. The contribution of Sri Lanka was highlighted as one of the important epidemiology groups that had highlighted some of the clinical features in MOGAD. So I'm going to go through a few cases here just to highlight some of the features of MOGAD. So the first one is titled Something to Keep an Eye On. So this was a 62-year-old woman who developed pain with eye movement after a respiratory illness. There was vision loss to the point where she could only see hand movement bilaterally at the nadir. And fundoscopy was abnormal. Again, another example of using your fundoscope here, but no relevant afferent pupillary defect, and was initially suspected to have an ischemic optic neuropathy. And increasingly, we're recognizing MOGAD as a mimic of ischemic optic neuropathy in older individuals. This was the fundoscopy showing bilateral optic disc edema here. That was very prominent and obvious. Just to highlight, this patient underwent an MRI. This is an MRI of the brain without fat-saturated images, and you can see here it's difficult to determine the signal abnormality within the optic nerves or here, but when you do the fat-saturated images, you can see the normal gray-appearing optic nerves appear very white here bilaterally. So this is an example of bilateral optic nerve enhancement. So if you have a patient who has suspected optic neuritis, it's really important to ask for orbital MRI with fat-saturated images, or otherwise it will be insensitive to detect optic neuritis. So that's a crucial component. In this patient, as we heard very nicely from Letitia earlier about the OCT was quite thickened on both sides. Usually the normal is between 80 and 100 probably, and here it was quite elevated both sides, consistent with what we're seeing on fundoscopy. And on the coronal images here you can see the bilateral optic nerve enhancement. This person underwent a CSF study and there was no oligoclonal bands. The cell count was normal. The MOG antibody was positive both in serum and in CSF. The titer was in the lower range, but still positive. So what about MOGAD optic neuritis? Well, as I mentioned earlier, it accounts for about 70% of all MOGAD attacks, maybe about half of the onset attacks, and it'll account for an even higher majority of the relapsing attacks. It can be bilateral in a third to half of cases, and it often begins with eye pain and pain with eye movement. So sometimes there might be a therapeutic window where a patient gets pain with eye movement before they develop vision loss, where you could jump in with early steroids. Optic disc edema is very common, so that's a useful discriminator from MS, as that's seen in less than a third of MS cases. And the episodes tend to be a bit more severe, so the median visual acuity is count fingers, but it tends to recover better than aquaporin 4. And here you can see an MRI. It tends to involve the anterior aspect of the optic nerves. You see inflammation right up to the fundus here, and sometimes you can see extension to the orbital fat or involvement of the optic nerve sheath, where you get this tram track of enhancement like you can see here. If you have bilateral involvement, bilateral anterior optic neuritis is very suggestive, particularly if it's longitudinally extensive, which means it extends greater than 50% of the length of the optic nerve, like we can see here. That's very suggestive of MOGAD and should be a situation where you're testing for MOG antibodies. As I said, on fundoscopy, we can see this swelling, and John Chen, one of our neuroophthalmologists at the Mayo Clinic, did a nice study showing that the median ORNFL thickness at the time of optic neuritis is much higher with MOGAD than it is with multiple sclerosis, consistent with that swelling that we see. And then the thinning in follow-up, you'll often see optic atrophy. We can see that bilaterally here, and that'll be also present on your OCT test. So the next case, I'm going to title OMG. This was a very severe case. This was actually one of the first cases when I joined the staff of Mayo Clinic that I was asked to consult on in our neuro ICU. And I may have shared some of the features of this case before, but it's a very illustrative case and good to go over. This patient had a viral prodrome and then developed headache and fever and some confusion, was initially diagnosed with aseptic meningitis and had somewhat of a meningoencephalitis type presentation, and then developed subacute encephalopathy and worsened to the point where they became comatose and quadriplegic, and then they were transferred to our institution, and on arrival they were intubated and mechanically ventilated as they were no longer able to protect their airway. Interestingly, the initial MRI was negative here, but then subsequently there were multifocal T2 hyperintensities within the cerebral white matter, both supratentorially and infratentorially, and then there was an evolving longitudinally extensive lesion that was mostly involving the gray matter on axial images. This patient had 139 white cells, no oligoclonal bands, infectious testing was negative, CSF cytology was negative, and aquaporin 4 antibodies were negative. And at the time, we didn't have MOG antibodies available, so this patient actually underwent a brain biopsy. We only had MOG antibodies available on a research basis, and we were able to confirm MOGAD later. But on brain biopsy, there was evidence of demyelination with loss of myelin here, loss of MOG and other myelin proteins, including MAG. There was evidence of prominent microglial infiltration, and there was also complement deposition in this case. The patient was treated with IV steroids and plasma exchange for 7 treatments, and in the interim, his research MOG antibody came back extremely high titer at 1:1,000. So the diagnosis was MOG antibody-associated disease, and he returned to our clinic 3 months later, and he was essentially normal. So he had really improved from being comatose and quadriplegic, as sick as a neurology patient can get, to get back to normal. He developed a recurrence with optic neuritis bilaterally 3 months later, and he was started on a steroid-sparing agent, initially with azathioprine, switched to mycophenolate, and later switched to tocilizumab due to some poor tolerability of the oral immunosuppressant agents. Just to highlight the radiological course, we talked a lot about the clinical course, but the radiological course, the initial MRI, as I said, was negative. Then subsequently, 16 days into symptoms, there was evidence of these hazy, ill-defined T2 hyperintensities and evolving spinal cord lesion. At 3 months, the lesions were disappearing. And then at 2 years, all of the lesions had essentially disappeared from the brain and from the spinal cord. But what you will notice is that there was development of atrophy. So, and this patient probably on cognitive testing does have some subtle cognitive but definite cognitive deficits. And his brain MRI volume is less than the first percentile. So while the lesions can disappear, there is damage with these episodes, and there is accompanying atrophy. So cerebral attacks, MOG antibodies are found in about 30 to 50% of patients who have a presentation of acute disseminated encephalomyelitis. And the MRI features differ from MS. I would say this is a very classical imaging of a MOGAD patient. You can see here these large deep gray matter lesions in the thalamus, in the basal ganglia, and then lesions within the white matter also. You can have leptomeningeal enhancement in up to 1/3 of cases with brain involvement. That's very different to MS, where on conventional imaging we don't tend to see leptomeningeal involvement. We can see involvement of the corpus callosum, but it tends to be more diffusely rather than the typical Dawson's fingers that we see in multiple sclerosis. And also in the infratentorial space, the lesions tend to be larger. We can see diffuse pontine involvement, larger lesions within the middle cerebellar peduncles, for example. So the next case I'm going to highlight is a pediatric case, and this was an unfortunate fatal case of MOGAD. This was an 8-year-old boy, and he had developed fever, headaches, and encephalopathy, had no prior medical history, had a very inflammatory spinal fluid, but infectious testing was negative, but there was a suspicion, given the fever and the headaches, that this was some sort of infectious meningoencephalitis. This was the MRI showing a restricted diffusion within the frontal lobes and T2 hyperintensity within the cortex here and extending into some of the white matter. His mental status deteriorated quite quickly and became comatose and was mechanically ventilated within 24 hours, over the course of 24 hours. And his pupils became less responsive and developed extensor posturing. In the setting of this complicated illness, developed ventricular tachycardia and stress cardiomyopathy. In the setting of his kind of neurological deterioration, was given a gram of IV methylprednisolone at that stage, but CT showed diffuse cerebral edema, and then a CT angiogram showed no evidence of any blood flow, and he was pronounced brain dead from this. So a very tragic case. After death, his MOG antibody returned highly positive at 1:1,000. So this was a MOGAD case of a fulminant attack and a fatal outcome. That is rare, but can occur, particularly with the first attack and in children. And up to 2 to 3% of patients can have respiratory failure with their first episode. This patient underwent an autopsy, and it was consistent with MOGAD, with changes of demyelination, microglial infiltration, and both cortical and subcortical demyelination, along with perivascular inflammation and sleeves of perivenular demyelination. So fulminant life-threatening attacks are reported in MOGAD. We had looked at the frequency of this, and it's about 2 to 3% that required mechanical ventilation. And there have been increasing reports of increased intracranial pressure during cerebral attacks of MOGAD. Up to 25% can have elevations in intracranial pressure. And here we can see some examples of diffuse cerebral edema and early signs of herniation here in this CT findings. And here you can see a larger tumefactive lesion with some midline shift and a herniation. This patient had to undergo a hemicraniectomy as a life-saving maneuver. There are some reports of interleukin-6 tocilizumab helping in the acute situation, so that's sometimes been used as a rescue treatment. Other times, CSF diversion has had to be used, or involving neurosurgical emergent hemicraniectomy has been used as a life-saving measure in some of these patients. So if you have a pediatric patient with a severe presentation, think about testing MOG antibodies and think about aggressively treating them, as some of them can be fulminant. In terms of other involvement of MOGAD, we can have a spinal cord involvement. We typically see these longitudinally extensive lesions, like the case I showed earlier, and sometimes on axial images, they'll have this involvement restricted to the gray matter that we call the H sign. We can sometimes see a long and a short lesion. About 30% of lesions can be short, and we can see involvement of the conus as a predilection. And these patients often have bowel and bladder impairment. They often require a urinary catheter, a bit different to MS, where they have milder urinary and bowel symptoms, and they can mimic the acute flaccid myelitis of enterovirus. So to remember this H sign, depending on your lineage, you might think about the Under Armour sign or the TIE Fighter sign. So we sometimes use some of these signs to help our trainees remember these features. Other involvement, we recently reported some of these patients can initially look like a meningitis and often then evolve into a meningoencephalitis, and sometimes the initial MRI can be negative, as we'll talk about. So we see this in up to 4% of MOGAD patients. They have an elevated CSF cell count, they may have fever, headache, and they may meet criteria for aseptic meningitis. And when you look pathologically, you'll see inflammation within the meninges, but the meninges actually do not have MOG staining within them, so we don't know if it's from secondary involvement or spread of the inflammation from the cortex into the meninges. There's also been cranial nerve enhancement reported and leptomeningeal involvement. Sometimes, as was mentioned earlier today, MOGAD with bilateral optic neuritis can mimic pseudotuber cerebri. And you have to be a little bit careful with low positive antibodies of MOG because there can be false positives that we'll talk about later. In terms of the MRI, this was a recent study that we did showing that about 10% of MOGAD cerebral attacks can have an initial negative MRI, or you may just see one lesion on your MRI and then you do a follow-up and it rapidly changes. So MOGAD is very dynamic in the acute situation, and you can see multifocal lesions develop. MS and NMO tend to be more static, so you'll see lesions over short periods of time enlarging, but you don't tend to see multiple lesions turning up or some lesions resolving over the acute period. That's much less common with MS and NMO. And then in follow-up, as we know, multiple sclerosis is, the term multiple sclerosis means multiple scars, and MOGAD tends not to form scars. So you can see multifocal T2 hyperintensities in an 8M episode, and in follow-up, almost all of the lesions are gone, with maybe just one lesion persisting here. And also in children, we see the same thing. While with MS, almost all of the lesions will resolve. They sometimes will reduce in size, but they tend to persist over time. And with aquaporin 4, we tend to see the lesions persist over time, although also reduce in size. And we recently showed that that if 2 lesions resolve on brain MRI, that completely will separate MOGAD from MS. Sometimes an MS lesion, you may see it'll either disappear or it's hard to see in the infratentorial space, so we can sometimes see one lesion of MS resolve, but almost all of the lesions in MS will persist. And this may teach us a little bit about the clinical course. Here we see a lesion in MOG that resolves. Here we see a lesion in aquaporin 4 that reduces in size, but there's persistent T2 hyperintensity. And then with MS, we see a smaller lesion and the lesion persists. And this fits with the recovery of MOGAD. You get a severe attack, you may be paraplegic or encephalopathic, but then tend to recover very well. And with each episode, if you are monophasic, which is about 50% of MOGAD cases, you may have no future relapses, or you may be relapsing where you develop future relapses, but the accumulation of disability after each attack is just mild. There is disability after each attack, but it tends to be mild. On the other hand, with aquaporin 4, the accumulation of disability is much greater after each attack, and that can leave residual deficits where after 2 or 3 attacks, a patient may be wheelchair dependent or walker dependent. And then with MS, we see milder attacks, but over time, the accumulation of lesions, and it may be that some of these spinal cord lesions in particular represent a nidus where they develop a secondary progressive course that we don't tend to see with MOGAD. New lesions are also uncommon in MOGAD, so surveillance imaging is not quite as useful. In MS, nowadays, with the high efficacy medications, we also don't see as many new lesions, but even MOGAD patients who are not on any treatment, they don't tend to develop as much new lesions over time, and that has implications for clinical practice. We don't tend to have to do surveillance MRIs as much, and it's not going to be as useful an endpoint in clinical trials as it is in multiple sclerosis, because the asymptomatic development of these new lesions over time is less common. Next, I'm going to go on to the last case. This is a patient who was originally from Southeast Asia. And again, this patient was initially suspected to have tuberculosis, which we discussed a little bit earlier. So they had a subacute headache, developed right-sided seizures, had fever and encephalopathy. As the CSF opening pressure was elevated, the white cell count was elevated, oligoclonal bands were negative, and the patient was placed on empiric antibiotics and later on TB-directed antibiotics while awaiting some additional test results. Was given dexamethasone as part of their meningitis treatment, and their seizures were treated with levetiracetam. And here was the MRI showing this T2 hyperintensity within the cortex, unilaterally here, with no real white matter involvement. And there's also evidence of leptomeningeal enhancement. So you can see the cortex is bright and swollen when compared to the other side. So this is what we term cerebral cortical encephalitis of MOGAD. And this patient actually underwent a brain biopsy because it wasn't recognized at the time, and they looked for tuberculosis and looked for other infections. They didn't find anything, but there was evidence of subpeel demyelination, along with other inflammation, prominent microglial infiltration too, and some meningeal inflammation within the meninges. This patient was seen in clinic 1 month later, and after being on a TB-directed treatment that was then stopped, and they had MOG antibodies tested because it was felt that this looked like a MOGAD attack. The MOG antibodies were positive. The patient's MRI of the cervical and thoracic spine were negative, and the OCT didn't show too much optic nerve damage. So it seemed to be just prominent cortical involvement. So we've looked at this in our cohort, and we found it's in about 7% of MOGAD cases that we can see this cortical encephalitis. They often present with headaches, seizures, encephalopathy, stroke-like episodes, and sometimes they get misdiagnosed initially as stroke or as an infectious meningoencephalitis. NMDA receptor antibodies can sometimes coexist, so it's worth testing for those if you have this phenotype. And here's another example of a case. You can see T2 hyperintensities within the cortex, and then again, meningeal and cortical enhancement. And the biopsy again can show this subpeel demyelination. And this was first reported by Agawa and colleagues from Japan, where they first noticed this clinical phenotype that we've now subsequently been able to recognize and better characterize. Just to highlight a little bit about the MOG antibodies. The MOG antibodies are quite a good test, but it's not perfect, and it's a much more problematic than the aquaportin 4 test, in that there's a not insignificant number of false positives. 1 to 2% can have false positives. And the methodology of the antibody testing is important here. So what we do is we have these HEC293 kidney cells. We transfect MOG onto the surface of the cell, and then we add the patient's serum, and if MOG antibodies are present, we add a secondary antibody with immunofluorescent tag, and then we can measure that using immunofluorescence, looking under the microscope, or at Mayo Clinic we use flow cytometry to measure that. And then we'll dilute the sample and see the strength of positivity. We can see how long it remains positive for through the titrations. And the titrations are important because the high titers are highly predictive of MOGAD. So if you've got a really high titer MOG antibody, it's much more likely. The risk of false positivity is much less. On the other hand, if you have a low positive result, there is a much higher proportion of false positives, and even can be up to 50% if you order in low probability situations. And this is highlighted when they did some assay comparison studies across multiple different regions. The clear negative results and the high positive results are very concordant across multiple centers, but the low positives are not. So you send the low positive to one center, it might be positive, the next center it's negative, the next center it's positive. So these low positive antibodies are tricky. Another thing we recently recognized is that the fixed cell-based assay it tends to be a little bit less sensitive, so you may miss up to 1 in 2 cases of MOGAD if you order the fixed cell-based assay, and the live cell-based assay seems to be much better at detecting MOGAD, and it may be that in that fixation process you lose some of the conformational form of MOG, and that might be a reason why it's harder to pick up with the fixed cell-based assay at times. So if you're highly suspicious, the live cell-based assay is going to be optimal. And because of this challenge with false positivities, we tried to come up with a score recently. We did this amongst our Mayo Clinic cohort, and then we validated it with the Johns Hopkins cohort. And we call this the True MOGAD score. The T stands for titers. If they're clear positive, you get 1 point. If it's relapsing optic neuritis, you get another point. If the patient is pediatric, you'll get another point. If they have this encephalitis phenotype with ADEM or cerebral cortical encephalitis, you get 2 points. If you have an MRI or supportive features per the criteria, you'll get 2 points. And then you lose points if you've got oligoclonal bands in your CSF, if you have a gradually progressive course, or if you have a hyperacute course, very sudden onset, suggestive of a stroke or infarct. And then in follow-up, if you have disappearance of the lesions, that can also help you. And this gives you a very good ROC curve. And the T, this all spells out True MOGAD. So this is will be coming out soon, and we're hoping to develop as an online calculator that people can use, so that when you get a positive result back, you can determine what's the likelihood that this is a true or false positive result. Just to finally mention, the diagnostic criteria for MOGAD have been published in 2023. This includes many of the clinical features that we talked about earlier in the talk today. You have to have a positive MOG antibody test. If you're high positive, you don't need any additional supportive features, but if you're low positive, you don't have a titer result available, or you're only positive in CSF, then you need to make sure you're aquaportin 4 negative and that you have additional supportive features, and many of those are the clinical and MRI features that we talked about throughout the earlier cases. And then finally, you need that exclusion of a better diagnosis, including multiple sclerosis, which, as Dr. Mantelbaum mentioned, gets a little bit circular. But these criteria are useful, and they can be summarized into 3 major parts. You've got your typical demyelinating event, you've got a positive MOG antibody, and you've got exclusion of a better diagnosis, including MS. So just to summarize, MOGAD, the frequency, it's overrepresented in children. They account for about 25% of cases. But as I mentioned to Brenda Banwell, she wasn't very happy with me because I said that MOG is an adult disease, because still 75% of cases occur in adults. But the pediatric component is important. The female to male ratio in a recent study we looked at, it's a slight female predominance. It's about 1.5 to 1, it looks like, but that's different to aquaportin 4 and MS, where females dominate more. It has its own unique phenotypes, many of which we mentioned in this talk, including the cerebral cortical encephalitis and ADEM, that are different. Oligoclonal bands are seen at about 15% compared to 85% of MS, so that's an easy way to remember, about 15% of aquaportin 4 too, so that adds up to 100%. The target is oligodendrocyte. It does not have a progressive phase, but it does have some challenges with false positivity. And then some patients will be monophasic, and we don't yet have proven treatments from clinical trials. The MRI features show longitudinally extensive enhancement. Sometimes you'll see optic disc edema. Sometimes that can even be visualized on MRI, and you can have involvement of the sheath or the anterior part, and it's longitudinally extensive and bilateral. While aquaportin 4 has more of a predilection for the optic chiasm, and MS lesions tend to be shorter. The spinal cord lesions, again, tend to be either longitudinally extensive or can be short and involve the conus and tend to disappear over time, different to the MS shorter lesions. And then the brain lesions, we can see diffuse involvement of the brainstem and the medulla or the pons, involvement of the middle cerebellar peduncles, deep gray matter and white matter involvement, this cerebral cortical encephalitis and leptomeningeal enhancement. And then in follow-up, most of the lesions will tend to disappear. So I'll stop there, and thanks for your attention. I'll be happy to take any questions.
Thank you, Prof. Flanagan, for the excellent talk. On the spectrum of MOGAD, we can entertain 1 or 2 questions.
Thank you for that. You said that the MRIs resolve with time. what happens to the antibodies? Do they remain or do they disappear with time?
It's variable what happens to the antibodies. So I would say initially 99%, over 99% will be positive at the onset. And then what we can see is that we'll see seroreversion in up to 50% over time. And those patients that serorevert to negative have a lower risk of relapse. But some patients, it's not perfect in that some patients will serorevert to negative, but then they come back to positive. And some patients have been reported to still relapse, even though they turn negative. So it's kind of a complicated situation, because sometimes they just drop just below the cutoff, but then they come back up. So sometimes there can be some transient seroreversion and seroconversion over time. So it's a little bit complicated. I think we need to learn more about it. For now, we usually make our treatment decisions based off of clinical episodes and attacks rather than serology. But in general, what tends to happen is the antibody is highest at the onset and then tends to go down. And some patients persist, but at a lower level, and then some patients serorevert to negative. If that makes sense.
Just another question is, you showed patients with focal encephalitis and quite a variable phenotype. Do you really think the target is MOG in all these conditions, because patients present with cortical gray matter features? Do you feel that the antibody is truly pathogenic and attacking the gray cells also, in addition to the myelin in the white matter?
Yeah, it's a great question, and I think it's something we don't know. You know, we did look in the meningitis, and we looked at for MOG expression in the meninges, and it's not expressed. But so the inflammation there may be arising from somewhere else. You know, it's interesting because we see MOG involvement in the deep gray matter in the brain, and in the H sign we see it in the gray matter. There is myelin still there within the gray matter, but I don't know the exact reason why that area is more predisposed. And then in some patients, they only ever get optic neuritis and they never get brain involvement. So I don't think we fully understand yet the reason. I think it is still unified by the MOG antibody. If you look at all of the cases, it's quite consistent. I think you have to be careful in the literature. Sometimes what you'll see is a low positive MOG antibody result and maybe a peripheral neuropathy, and they'll say it's expanding the spectrum of MOGAD. We call it this phenotype creep. But in reality, a lot of those are probably false positives, and you know, there's not very good control studies, because if you look at MOG in other control situations, it may be present in up to 1%. So you've got to be careful. But the ways to extend the phenotype, for example, with the cerebral cortical encephalitis, is a lot of those cases are very high titer MOG, and then a lot of them go on to develop optic neuritis later. So they go on to have a typical phenotype. So I think it's still part of the same disease, but I don't think we fully understand the reasons why these different sites are involved. And we've also been interested in microglial PET, and we've looked at that and see much more extensive involvement than we see on MRI. So maybe there's more happening than we see on the MRI too. But great question, yeah.
Thank you.
Yeah,
Congratulations for your great talk. You said that the MRI lesions, we know that the MRI lesions tend to reduce and sometimes disappear in MOGAD, while in the optic nerve we see a great extent of atrophy. So I wonder if you can tell us more about the lesions, the MRI lesions in the optic nerve. Do they also tend to disappear, or do they stay there?
Yeah, it's a great question. I think it's something our team is looking at. I think the T2 hyperintensity is harder to evaluate in MOG. We also have looked previously at persistent enhancement within the optic nerve, and sometimes we'll see that in 3 to 10% of cases, usually at the site of prior inflammation where it persists. But I don't think the lesions resolve quite as consistently within the optic nerve, and I'm not sure if that's just the extent of inflammation within a smaller area that is harder to kind of resolve completely. I don't know, but it seems like the signal seems to persist a little bit more, but I don't have an exact reason. And then I thought it was interesting in your talk earlier, you were talking about how the changes in the optic nerve tend to align quite well with the MRI changes over time, and that you know, it kind of reaches a new baseline at about 9 months, similar to what you're saying with the MOG. So the degree of recovery, we could probably learn a lot across the different aspects about how that's, improving, and what are the factors? Like, is there resolution of myelin edema early on, and then is it remyelination? Because we see some lesions disappear very quickly in MOG. So there's a lot we could learn about the optic nerve from all the studies that you and others are doing, and that we could probably apply to what's happening with the imaging with MOG. Yeah, thanks.
Just a quick question, Owen.
Yeah.
With regards to, just to follow up on Tashi's question about the antibodies. Now, when we follow up a patient who's MOG positive, when you advise us to do a repeat study or repeat testing? Because when we did the study, we were retesting patients for MOG, and after 2 or 3 times testing, it became negative. Yeah. So, do you advise us to retest them while they are on immunotherapy?
I think it's still, clinically, it's probably not going to make your clinical decision for you, but will it give you some helpful information? Maybe. So I suppose it might tell you that they're, if you repeat the test at 6 months or at 12 months and they're negative and they're not on any immunotherapy, it tells you that they're less likely. So maybe in terms of your surveillance or how often you're going to see them back, while if they're still persistently high positive. So it may help a little bit, but in general, we again would make our clinical decisions more based on attacks and things like that. But it does give some information, but it often won't change your management, I would say, because your management will mostly be based on if they have new clinical attacks. Yeah. Thanks.
So, thank you, sir. Again, so we have enjoyed the many phases of MOGAD. So it's time actually to learn about the pathogenesis, immunopathogenesis. So the next talk would be on immunopathogenesis of MOGAD. And let me introduce Professor Kazuo Fujihara, President of PACTRIMS, and in the Department of AMS Therapeutics in the Fukushima Medical University in Japan. Professor Fujihara is a well-known person in our SL trims, and he has been a constant present with us. So I can see him waiting virtually. I would have been very happy to see him again physically. So this time we are missing you, sir. But thank you very much for agreeing to present.
Thank you. Thank you very much for the kind introduction. Unfortunately, I cannot join you on site this year, so I'm joining you from Japan. When I visit Colombo, my another important mission is to buy the high-quality Ceylon tea for my wife. So I cannot do it this year, but fortunately, last year, I purchased a huge amount of Ceylon tea. So my wife is very much confident that it can last until next year. So maybe next year, I would like to visit Colombo again. So in this presentation, I'd like to talk about immunopathogenesis of MOGAD. Unfortunately, we do not fully understood the pathogenesis, but I'd like to share with you what we know at this point, including our group's own data. So these are my disclosures. So let me start with this. Immunopathogenesis of MOGAD may be classified into these 3 phases. The firstly, genetic susceptibility and the breakdown of immune tolerance. And secondly, trigger of disease onset. And thirdly, persistent autoimmunity to MOG. As for genetic susceptibility, we do not know much, but a few studies show that there's no strong HLA association, and other studies show that some gene polymorphism may be related to disease susceptibility. And as for breakdown of immune tolerance, there are a few reports on the impairment of regulatory T cells and B regulatory cells. But in my talk, I'd like to focus on that phase 2, which is the trigger of disease onset. For inflammation, a number of humoral and cellular immune factors involved in the process. And as a result, a demyelination occurs with some axonal damage. And finally, I'd like to talk a little bit about the persistence of autoimmunity to MOG, in particular in relation to relapses. So as you all know, some of the patients may have infectious prodromes, and somewhere between 20 to 40%. And as you see on the right-hand side, a number of different infections have been reported. In a Japanese nationwide survey, a pediatric onset group had higher frequency of infectious prodromes than adult onset groups. And there are a small number of post-vaccinal onset of MOGAD. And again, based on the Japanese nationwide survey, top two were influenza vaccination and the Japanese encephalitis vaccination. And also, there are some cases of post-COVID-19 vaccination cases of MOGAD. Let me talk about cytokine chemokine profiles. We previously reported that during the acute phase in CSF, in both MOGAD and AQP4 positive NMSD, IL-6 and other Th17 related cytokines are very much upregulated in comparison with MS and control. On the right-hand side, you can see the significant correlations of CSF cytokine pairs. For example, if IL-6 and IL-8 are significantly correlated, that box becomes black. And as you see here, in MOGAD and AQP4 positive NMSD, a number of cytokine pairs are significantly correlated, and the pattern seems to be relatively similar between the two autoantibody-associated CNS inflammatory disorders. But in this cohort, surprisingly, in MS, no cytokine pair was significantly correlated. So we can say that coordinated upregulation of multiple Th17-related cytokines occur in the acute phase in MOGAD and AQP4 positive NMSD. MOGAD is a demyelinating disease, and here I can show you a MOG positive case with NMO. The patient was 31-year-old male, and he developed right optic neuritis, but the recovery was quite good. But 2 weeks later, he developed acute myelitis, extending from cervical to thoracic region, so relatively long. And again, the recovery was good. And he was negative for AQP4 IgG, but was positive for MOG IgG. And we measured myelin basic protein and GFAP in the CSF as a marker of demyelination and astrocyte damage. As you see here, MBP was very high, while GFAP was less than detection limit. So although this patient had a definite NMO based on the diagnostic criteria, but this is a severe demyelination with no astrocytopathy. Later, we did an international collaborative study, but again, we confirmed that CSF GFAP was not elevated in MOG positive cases, regardless of clinical phenotypes. This is very much in contrast with the very high elevation of GFAP in AQP4 positive NMSD cases. MBP, which is a myelin damage marker, was relatively high in MOGAD, and in this study, it was significantly higher than MS cases. MOGAD is not purely demyelinating. It may cause neuroaxonal damage as well. And there are some few studies that show that serum tau or neurofilament light chains were significantly elevated, and it may be significantly associated with relapse or the EDSS scores. So it's not purely demyelinating disease. Robert Furlan And David Reppert and colleagues recently reported that in the acute phase of CSF in MOGAD, granulocyte activation marker GAM, like neutrophil elastase, myeloperoxidase, matrix metalproteinase 8, and neutrophil gelatinase associated lipocalin NGGAL were significantly elevated in the acute phase. It was also seen in NMO-SD. Kevin O'Connor's group at Yale University a few years ago reported the pathogenicity of MOG antibody in vitro. They used MOG IgG1 monoclonal antibody and live MOG expressing cells in vitro, but I do not go into the detail, but they demonstrated that MOG antibody is pathogenic via complement-dependent cytotoxicity, CDC, antibody-dependent cellular phagocytosis, ADCP, and antibody-dependent cellular cytotoxicity, ADCC. Their report included a single case of biopsied case of MOGAD, and neuropathological finding was reported. I think Professor Flanagan presented the same case in his presentation, but as you see here, A and C shows the active demyelinating lesions, D and E are complement deposition, and F and G shows the CD68 positive macrophage and microglia infiltration. And they show that IgG binds to MOG, and as for effector functions, they show that membrane attack complex or MAX was formed, and dead cells are mostly MOG positive cells, and they also show that the phagocytic activity and MOG expressing cells are decreased as a result of this phagocytosis. So it seems the MOG IgG is pathogenic. As for histopathology of the disease, we previously reported that perivenous demyelination, as you see here, were relatively common in MOGAD. And actually, this histopathological pattern was reported in ADEM before MOG IgG was widely recognized. So it was reported in ADEM. And in those lesions, in the acute phase, as you see here, CD68 positive macrophage infiltrations are seen. And a few years ago, we reported that as a pattern of demyelination in MOGAD, ADEM, like perivenous demyelination, was dominant. On the other hand, confluent demyelination was relatively rare in our series. However, Romano Hoftberger's group reported that the transitional pattern with perivenous and confluent was seen in nearly half of the cases they studied. I'll come back to these findings later in my talk. And as for lymphocyte infiltration, it was T cell dominant, and among T cells, a CD4 dominancy was observed, in contrast to the CD8 dominancy in multiple sclerosis. We recently reported the CD4 T cell response to MOG peptides, but we did not add any cytokine to stimulate T cells, and we observed a very mild CD4 T cell response to some MOG peptides. But this aspect should be studied further by other groups. But the pathogenic role of MOG-specific T cells is still not clearly understood. This is an in vitro study done by a German group. So they used the animal model. They transferred MOG antibody and MVP-specific or MOG-specific T cells. As for T cell infiltration, as you see here, MOG-specific T cell transfer induced significant T cell infiltration. But on the other hand, in terms of demyelination area, for some reason, by the transfer of MOG-specific T cells, demyelination was quite small. But on the other hand, by transfer of MVP-specific T cells, you observed a very extensive area of demyelination. And in this model, so you see the deposition of activated complements and human IgG. So the pathogenic role of MOG-specific T cells should be studied further. And as for macrophages, as you see here, in MOGAD, there's an extensive macrophage infiltration in comparison with other CNS inflammatory disorders. And as for the deposition of perivascular deposition of activated complements, unlike AQP4 positive NMSD, in MOGAD, there are very few perivascular deposition of activated complements. But again, Romano Hofberger's reported different results. They reported that in all cases they studied, they demonstrated the complement deposition. Then what makes these differences? So perivenous demyelination versus confluent demyelination, and mild or no complement deposition versus dense complement deposition. Is it because of the different cohorts, different staining technologies, different interpretation of data? To resolve this issue, my young colleague Yoshiki Takai went to Roman Hofberger's lab and analyzed their cases and our Japanese cases by the same method of immunohistochemistry. I do not go into the detail, but let me jump to the conclusion. But the most important observation by Yoshiki was there were two different complement deposition patterns in MOGAD. Type A is weak C9 deposition, and type B is strong C9 deposition. So this is type A, essentially very mild or no C9 deposition, while in type B, you can see a strong and dense C9 deposition. And on the right-hand side, this is a comparison of the patterns in biopsied cases and autopsied cases. In biopsied cases, type A, weak C9 deposition was dominant, while in autopsied cases, type B was dominant. Essentially, in all autopsy cases, patient passed away in the acute phase of severe MOGAD. And in this slide, I'd like to draw your attention to here. So TPP, tubulin polymerase promoting protein expression. In type A, TPP expression is quite intact, while in type B, the staining is extensively lost. And TPPP is expressed exclusively in mature oligodendrocytes and the myelin sheath. So you can say that in type B, myelin is severely damaged. And on the right-hand side, you can see that in MOG type A lesions, TPPP positive cells are retained, but in type B lesions, very few type PPPP positive cells. So this is the summary of the neuropathological features in MOGAD. So in our study, perivenous demyelination was dominant, while the confluent demyelination was relatively rare. And that infiltrating lymphocytes are CD4 dominant T cells, and the perivenous macrophage accumulations are relatively intense. And we observed two patterns of complement. deposition. So as for demyelination, I think probably in early phase of the lesion, demyelination pattern is perivenous, and they are multiple. But over time, they become expanded to form a confluent demyelination in later phase. And what about complement deposition? Probably complement deposition is weak in mild disease, while in severe cases, it may be strong. So as for the differences of two studies, our studies probably saw cases in relatively early phase in mild disease, but while on the other hand, Hofberger's cases were relatively early, relatively later phase in severe disease. Australian group recently reported that there was a significant increase of proteins indicative of systemic classical and alternative complement activation in MOGAD versus control. So one question may arise. Is complement inhibitor, more specifically, is C5 inhibition effective in MOGAD, just like what happened in AQP4 positive NMOSD? As I mentioned earlier, so MOG IgG is pathogenic via CDC, ADCP, and ADCC. However, as I showed you, there are two patterns of complement deposition in MOGAD, and Marcus Reinder's group a few years ago reported in their in vitro study that for some reason, both MOG IgG and AQP4 IgG belong to MOG IgG1. For some reason, MOG IgG's complement activation is weaker than AQP4 IgG. Probably in accordance with this in vitro study, a few years ago, we reported complement components elevation in MOGAD and AQP4 IgG. And as you see here, C5a is equally elevated in MOG and AQP4 positive NMOSD, but the C5b9 or membrane attack complex was significantly lower in MOGAD in comparison with AQP4 positive NMOSD. However, in MOGAD cases, if you classify the disease into two cases, severe MOGAD and mild MOGAD, in severe MOGAD cases, C5b9 were high, but in milder cases, there was no elevation of C5b9 concentration. So in severe cases or in life-threatening MOGAD cases, a C5 inhibitor may be effective as a rescue therapy. There are some therapeutic outcomes that may have implications in the immunopathogenesis of NMOSD. Australian group recently reported that if the patients received corticosteroid whose dose is 12.5 milligram or greater per day for at least 3 months, in comparison with those never treated, they saw almost 90% risk reduction of relapse. On the other hand, Korean group reported that if you start early acute phase treatment for onset event within 5 days, which is early, in comparison with intermediate or late start of acute phase treatment at onset attack, you can decrease the risk of relapse significantly. So these data may suggest that if the initial treatment is insufficient, it may allow the persistence of MOG autoimmunity, and some of the patients may experience relapse in the later course of the disease. To sum up my talk, so I'll skip the phase 1, and as for phase 2, which is trigger of disease onset, infection and vaccination may be involved in some cases. And as for the inflammation, various immune components like upregulated Th17 cytokines and granulocyte associated molecules, MOG reactive T cells, and the pathogenicity of MOG IgG, complements, granulocytes may be involved in causing inflammatory demyelination. And lastly, as I mentioned, if the acute phase treatment is insufficient, it may allow persistence of MOG autoimmunity, and some of those patients may experience relapse in the later course of the disease. With that, thank you very much for your attention.
Thank you, Professor. Your talk was very informative, and I think our audience will be interested to ask any questions. Yeah, Dr. Anomaly.
Thank you very much, Professor Fujihara. I think like over the years, we are learning a lot more and more about MOGAD. And may I know, can I ask like with the MS variants like Bell's concentric sclerosis, Marburg's variants, are they related to MOG disease, or is there in relation with the pathogenesis you explained?
Well, I do not know much about the pathology of Bell's concentric sclerosis, but MRI patterns are quite different, and I do not know the in-depth analysis of cytokine chemokine studies were done, but I do not know any case of Bell's concentric sclerosis in which the MOG IgG positivity was confirmed. I don't know. Owen, do you know any such case in your experience?
No, great question. I think I haven't seen it. You know, we looked before, we did a comparison of some of the imaging findings across tumefactive demyelinating conditions, and we found that the Bell's was only seen in the MS group and was a feature of MS. And, you know, the MOG cases, we showed some fulminant cases earlier where they can have fulminant involvement, and the Marburg variant of MS is interesting where they can also have fulminant life-threatening attacks, but I think they're probably different overall, would be my experience. But I don't know as much about the pathology. Yeah, thanks.
Thank you so much.
Can I ask a quick question as well while I'm here? What do you think in terms of, you know, you talked a lot about the different pathogenesis, in terms of other treatments, other than what we have now? We have a few clinical trials of IL-6 blockers and FcRn blockers. Is there any other treatments that you think would be interesting as a relapse prevention treatment or as an acute treatment? I think complement inhibition, from what you're saying, might be a potential acute treatment for very fulminant attacks, but anything on the attack prevention that you would be interested in, BTK inhibitors for microglia or anything else that you think might be worth trying?
Well, that's a great question. And as for acute phase treatment, Owen, you already mentioned that in some life-threatening cases, IL-6 blocker like tocilizumab was shown to be very effective. And our pathological data may suggest that in some cases with life-threatening MOGAD complement inhibitor may also be a treatment of choice. But of course, the first-line treatment may be the IV methylprednisolone and the plasma exchange, and so rescue therapies may be considered after those first-line treatment are found to be ineffective. But as for the long-term relapse prevention, BTK inhibitor, it's a great question. I'm not quite sure, but as for the international clinical trials, meteoroid IL-6 receptor monoclonal satralizumab. That trial was already finished, and we are waiting for the top-line results. So they hope that the meteoroid top-line results may be presented in AAM meeting this year. So, otherwise, I do not have a very good idea.
So in the absence of any further questions, let us bring the symposium towards the end. It is the time to appreciate both the speakers for the very good talks. As Professor Fujiwara, let us appreciate by applause. Professor and again, if I can invite you to come up to receive the certificate from Dr. A.T. Aliboy.